Dear friends, it's my great pleasure to start the 21st update of spine surgery webinars. This time it's a very hot topic, endoscopic discectomy. Which technique is better? Dr. Joachim Ortel, Dr. Woo-Keun Kwon, and Dr. Hikmet Ulu are our distinguished speakers, and Onur, Yaman, and Farukh Karimov are our moderators. Now I give the words to moderators. Onur and Farukh, please.
Yeah, thanks, Professor, for inviting me to be like moderator. Actually, this is a really hot topic about the endoscopic modalities, and nowadays we have several options, and each one has advantages and disadvantages. And let's listen our speakers. First speakers, Dr. Woo-Keun Kwon. He's talk about biportal endoscopy. Please, Dr. Kwon.
Thank you very much for your introduction. Please let me share my slide for a second. Hello, I hope the screen is okay.
Yeah.
Can you see my screen? Thank you very much. Once again, thank you very much for your introduction. I am Woo-Keun Kwon. I am working at Korea University, Seoul, Korea. It is a great pleasure and honor to have this opportunity to talk for the 21st update of spine surgery. So today, I want to start with a full disclosure. I was assigned for the biportal side of this debate, yet honestly, uniportal surgery dominates my OR schedule. I still do both. So I decided to take the high road. I decided to play the good guy role and acknowledge both techniques fairly. Then I will explain why biportal surgery still deserves its certain place and having a certain role. So let's see if I can even convince myself here. So this is how it's going to be. To start with a very brief introduction, we definitely have uniportal and biportal surgeries. Uniportal surgery includes transforaminal and interlaminar approaches, and biportal surgery is a very flexible technique. We can do interlaminar, we can do transforaminal, and many other approaches as well. Basically, the significant difference is the different number of portals, but this distinct differences gives all the significant characteristics of each different procedure. To talk about uniportal transforaminal approach, it basically targets the Kempin's triangle, which is known to be the safe corridor towards the intracanal area. So this area is where we target, and the big advantage is that we can reach this area without taking out the bone or taking out the ligaments or anything other than that. To talk about interlaminar approaches, thanks to the advance of technology, thanks to the advantage of our devices or our instruments, now we can deal and treat a lot of more complex pathologies than we could in the past. Starting from very simple lumbar stenosis decompressions, now we can move all the way up to the cervical spine, and we can also do very detailed and very complex decompressions in the thoracic area as well. To talk about biportal surgery, just like I mentioned in the earlier comment, it is a very much flexible technique. And one of the biggest advantage of biportal endoscopic surgery is that it is very, very identical to open procedures, which we are very much used to during our training as a spine surgeon. So basically, it gives two small incisions. We create a certain little bit of...
Sorry.
We create a certain space there, and then there goes the endoscope. So the surgical view itself is very much similar to open procedures. If we look into the existing evidence, let's look to a little bit of the comparative studies comparing uniportal versus biportal surgery. If you look into these existing literature, there's pretty good evidence that uniportal tends to have a little bit shorter OR time, a little bit shorter hospital stay. On the other hand, biportal surgery provides a greater canal expansion, and in terms of discectomy, it reports to have a little bit lower recurrence rate compared to uniportal surgery. So there are some certain differences here, but overall, they report similar clinical and radiologic outcome, including the complication rates. This is a small report about cervical. I just wanted to mention that we can also do cervical discectomy with uniportal and biportal surgery. And similar to lumbar procedures, it once again shows a little bit of advantage of lesser intra-op bleeding or small incisions in uniportal surgery. However, overall, once again, the clinical outcome, radiologic outcomes, or complication rates are not really that different. So overall, the scientific evidence says no significant difference between the two techniques. But let's get back to the characteristics of two different procedures and look into the details in order to try to get the maximum advantage of both techniques. If we compare these two, once again, are there any certain indications? No, there are not. There's no golden standards yet. And understanding unique characteristics of each different techniques can actually help us to harness their strengths to achieve optimal outcomes for each specific patients or each specific pathologist. If you look into the differences, the technical differences between uniportal and biportal surgery, the first characteristic that is significantly different is the visualization principles. To say about uniportal surgery, it is very similar to microscopic surgery or tubular surgery. We look into the corridor with the same angle where our instruments come in and move inside there. So both the scope and the instruments are aligning in the same angle. On the other hand, if you look into biportal surgery, there is a little bit of discrepancy between the scope and the instrument's angle. So this may show a little bit of discrepancy of what you see and what you do inside there. And this can affect you a little bit in your early learning curve. This is more significant for neurosurgeons because they are not used to arthroscopic procedures in their residency or their fellowship training. It might be a little bit easier for the orthopedic surgeons because they're already very used to arthroscopic procedure. However, this is a little bit of the key differences between the two techniques. To talk about the instruments, in uniportal surgery, the camera and the drills are at the same angle, at the same corridor, same channel. So basically, they always move together. What you see is what you can do. However, in the biportal procedure, there's a little bit of discrepancy. So the drill angle is a little bit different from what you see. And actually, these two, the camera and the instruments, they need to meet at a certain tip, which we typically call the triangulation. So a good triangulation is extremely important in biportal surgery. Another key characteristics is that as uniportal surgery is a single axis surgery, which means the scope and the drills are always moving on the same axis, you need to understand that it's not the right hand that does most of the work. Basically, your right hand is putting the switches on and off or grabbing and releasing. It doesn't really move the axis of the procedure. So basically, when you move your left hand where the working channel is, this is the part that does the most of the work. It has advantages as it's basically holding the same instrument with your two hands. It gives you a very, very firm handling, which means it can be safer. On the other hand, in biportal surgery, it's not your left hand doing the procedure, it's your right hand doing the procedure. Your left hand is holding the camera and giving a stable visualization, while your right hand does most of the work, the drilling, the manipulation, the grabbing, retraction, everything. This means for most of the right-handed surgeons, Just like you are drawing a picture or like writing something, you can do a very, very precise drilling compared to uniportal surgery. And at the same time, we need to keep in mind that there's always a pitfall. Sometimes this means that you are doing something floated and could be unstable at some points, and slipping or jumping while doing an important procedure could happen at any time. So it's extremely important to understand that and be careful not to injure any of the important structures. And at the same time, you need to understand there's a certain chance that you can also hit the camera with a drill and give damage to your instruments. So let's look into the advantages of each different techniques. Let's start a little bit with uniportal's advantage over biportal. So basically, based on the nature of the procedure, uniportal is at least one portal less invasive. That's the reason that I dominantly do more uniportal than biportal. However, it is at least one portal less invasive. It requires a smaller working space, which means lesser soft tissue damage. And looking into and working in the same corridor means that you are able to coagulate the insertion tract when you are withdrawing the instruments at the final stage. So it gives you a better chance of lesser muscle vessel hemorrhage. So typically when I do a uniportal procedure, I do not put a drain. Another advantage of uniportal over biportal is that there can be little or minimal lesser bone work compared to biportal surgery when you're reaching the interlaminar area. You can basically just follow the original track between the spinous process and the interlaminar window, and undercutting the lamina is possible rather than taking out the whole lamina and making a big laminotomy. Inevitably, biportal needs a little bit more laminotomy because once again, your instruments and your camera are not coming in through the same corridor. And an additional corridor for working channel means a little bit more laminotomy. To say about transfemoral approach, this is one of the hard to beat advantages of uniportal over biportal. If you look back to where and how endoscopic spine surgery started, it was from transforaminal procedures. It is still the least invasive way to reach this canal through a single portal, not cutting anything, but basically through the muscles and giving minimal damage to the normal adjacent structures. So this is one of these certain, of course, we could do a transforaminal approach with biportal, but it gives a much longer trajectory and much more soft tissue work inside there. So this is a certain advantage of uniportal surgery. The reason that this is possible is because if you look into the anatomy of the lumbar spine, the foramen tends to get larger and larger as we go up to the higher segments of the lumbar spine. And at the same time, the interlaminar space gets narrower at the upper lumbar segments. So if we look into the higher level discs, it's much easier and safer to get through the foramen rather than getting through the interlaminar window and cutting out more and more laminotomy to reach the certain area. To talk about thoracic herniations or thoracic pathologies, once again, transforaminal approach is one of the least invasive ways to reach the ventral part of the thoracic disc. So this is a certain advantage of uniportal. I'm sorry for the sound. So another advantage of uniportal is there is a little bit lesser concerns in terms of water pressure related problems. While in biportal procedures, you always need to maintain a good outflow of the water irrigation in order to avoid any possible increased pressure inside there. Uniportal surgery just consistently gives an inflow and outflow through the same corridor, so there's a little bit less concern regarding water pressure problems. Now let's talk about the real advantages of biportal. If I looked into several of the previously mentioned advantages of uniportal surgery, it's mostly about the patient. It's mostly about the pathology. But I haven't talked about anything about the surgeons ourselves. But we'll look into the advantages for the surgeons ourselves. biportal surgery provides significantly better ergonomics in terms of surgical posture of the surgeon. While we need to raise our hand up high in many uniportal procedures, just because of the nature of the trajectory, biportal surgery can be just the same position as we used to do in microscopic procedures. So the pressure on your arms, your shoulders, or your neck, everything is much easier and much more comfortable for surgeons in biportal surgery. This becomes extremely important when we are dealing with much more complex diseases that will take longer work times, or multi-level diseases that require longer work time. So in terms of ergonomics, biportal uh, has many much advantages over uniportal surgery. Another advantage of biportal surgery over uniportal is it gives you a much wider view, and gives you a much more freedom of extending and magnifying the view that you see inside the surgery. The wider range of visualization can be easily achieved by just simply sliding the scope out a few millimeters, and it's going to give you a much wider view inside there. In contrary, in uniportal surgeries, you cannot take out or you cannot withdraw the outer working channel, because that's exactly what is blocking all the muscles from coming in to obstruct your view to see inside there. So this freedom of having the ability to magnify the view and having a wider view in biportal is extremely helpful in understanding the anatomic orientations inside there. It's not only important or easier for the surgeons who are starting biportal surgery, but this is also very important for experienced surgeons as well, because it gives you much more freedom inside there. Another advantage of biportal over uniportal is that you can have a much closer look inside the canal. If we say that the diameter of the scope is the same, biportal surgery gives you a much higher resolution, better image, because basically uniportal surgery has to have a working channel, or needs to have a irrigation channel, and then have a camera inside the same diameter of the scope. Biportal surgery can use this whole diameter solely for the camera. So basically, technology-wide, you can always have a better view in biportal surgery with the same diameter. So with the same or similar resolution, uniportal surgery needs a relatively larger scope, and this means it needs a little bit larger laminotomy to get to the deeper side, to the contralateral side. And it's much easier for biportal surgery to put this narrower camera to the other side, the contralateral side, and easily reaches there and gives you a perfect view of where you need to go. So this is one of the unbeatable advantages of biportal. It significantly has a better resolution of camera. This becomes really important when, especially in the Far East Asian patients that I treat a lot, they typically have a very small body, and sometimes when you're treating an adjacent segment, there's not enough space between the screw head and the spinners process that we cannot actually put a uniportal scope inside that gap. In those specific cases, it is much easier, much safer, and much less invasive to use a much narrower, smaller biportal scope and do the procedure. So this is another advantage of biportal surgery. Another thing is that in uniportal surgery, because there is only one single axis, the pivot of your movement is typically on your lamina. Your instrument is docked on the lamina, and that's where the axis is. Even if you want to move from this side to that side, from the ipsilateral to the contralateral side, your scope is basically landing on the lamina, and there is where the pivot is. This means that your instrument is going to be a little bit stuck on your skin incision, and it restricts your area of freedom to move inside there. On the other hand, biportal surgery has the pivot at the skin incision, which means by using this skin incision pivot, you can easily tilt a little bit, just a little bit of the scope, and it reaches much more wider area inside the canal. So to say about a contralateral access and trying to have a view of the both routes, the contralateral exiting and traversing route, is really hard to do with the uniportal procedures because the pivots at the lamina and hard to reach two different areas. But in biportal surgery, it's very easy to simply switch a few millimeters or a few degrees and reach the two different routes. So this is once again giving you a wider freedom of movement inside there, which means you can deal with much more complex procedures. If I would need to name one single advantage of biportal surgery over uniportal, I would say the freedom of equipment use. While uniportal endoscopy has to have their own dedicated, own custom designed instruments to fit the uniportal scope working channel, conventional surgical instruments are totally applicable, and you can utilize any of your favorite open surgical instruments in biportal surgery. It significantly enlarges the freedom of equipment use, which means a much more precise or much more complex or maybe much more optimized instrument use for your patients. So this freedom of instrument use is an enormous advantage of biportal surgery. So based on these characteristics and based on these advantages of both procedures, this is how I utilize these different techniques in my practice. Are there certain indications for uniportal or biportal surgery? No. The scientific evidence says no, there are no significant differences. It's only that they work a little bit differently in different hands. So in both techniques, it delivers equally good outcomes in the hands of experts. If you're an expert in uniportal, you can pretty much deal most of your pathologies with uniportal. If you're an expert in biportal, once again, you can do most of the procedures with biportal. But I think what I want to emphasize here is that it's always good to leverage the strengths of each techniques to their fullest advantage and tailor it to the needs of each cases. And this is going to having both advantages in your hands. So for certain higher level extraforaminal or higher level discs or extraforaminal discs, I tend to choose uniportal surgery, while for contralateral double root exploration, biportal is my choice. For a single level ULBD, I would prefer uniportal surgery, but for adjacent segment problems, I would definitely use biportal surgery for the freedom of my instruments. For cervical cases, thoracic cases, I mostly use uniportal because there is a certainly lower risk of water pressure related problems. And for thoracic discs, transforaminal uniportal is the most less invasive way. So that's what I do with uniportal. However, in much more complex scenarios with much more bone work to do, if there's a need of much more use of various instruments, obviously biportal surgery is my choice. And in terms of surgeons' ergonomics, multi-level diseases more than 3 levels, biportal is way much easier and faster, better for the surgeon, better for the patient. To summarize, these two techniques are similar, but there are distinct differences. Both can treat a wide range of lumbar pathologies under the hands of experts with similar outcomes both clinically and radiologically. However, considering these characteristics, there are pros and cons, and plus you need to consider your clinical setting when choosing your technique. However, I think it's important to understand the advantages of both, and the best would be having both in your hands and take the advantage of both. Thank you very much.
Yeah. Thank you, Professor. Thank you, Dr. Kwon, for really great lecture and great talk. And really, it's can see advantages all of the methods also. Next speaker, Hikmetullah.
No, actually, Farukh, we can get questions.
Yeah.
We have some time for discussion.
Yes, I'm happy for any questions.
Yeah. I just want to ask that you don't prefer biportal endoscopy for transforaminal disc herniations, or sorry, for extraforaminal disc herniations.
Yeah,
You say this.
yes, I prefer uniportal for extraforaminal disc herniations.
What's the main reason of that?
So with a uniportal approach, if you are reaching the foraminal area or the extraforaminal area, you can simply put the working channel in through the muscle. So basically, there is no muscle work, no bone work, no ligamental work, and you can just land on the disc and take the disc out. It's much more straightforward and less invasive. We can do biportal transforaminal approach as well. It also gets through the muscles, but I believe there are two disadvantages of biportal for transforaminal procedures. I think the trajectory gets longer. There is much higher risk of water outflow obstructions because the corridor is longer compared to interlaminar procedures. You need to have extra caution on the water outflow. That's one disadvantage. Another one is just simply one incision is less invasive than two incision.
Yeah. What about the cost of the basic instruments? Do you think it is different than uniportal?
Yes,
You didn't mention anything about the expenses.
Yes, exactly. I wanted to focus on the medical thing, the clinical thing. So I did not mention the socio-economic thing. Yes, that is true. That is my bad. But we need to admit that the fundamental, the basic cost of setting up the technique or setting up the instrument is incomparably higher in uniportal surgery. So basically, in biportal surgery, you can ask any of your orthopedic arthroscopic colleagues and start with their instruments in the beginning. But for uniportal, you definitely need to have this dedicated system, dedicated instruments, everything. So in terms of the cost, yes, you are correct. Uniportal is too much higher expense.
What about drilling? Drilling, is it easier with biportal than uniportal?
I think I mentioned it in my talk earlier, but in terms of safety and firmness, I think uniportal is better because you're basically holding your drills with your two hands. But sometimes holding with your two hands makes the work hard to do it precisely. So when you are doing a very delicate work, a very precise work, I think biportal surgery is easier for that, as you can gently handle it, just like handling a pencil or a writing. So I think in terms of preciseness, I think biportal has advantage.
Okay. I think there is one question. Farukh, you can read the question from the chat.
Yeah, one of the questions, which is how much saline is used as irrigation in both uni versus biportal? Which one is the more?
I always use a pump, and for lumbar procedures, I start with 30 to 40 millimeters mercury, and occasionally, due to bleeding or for more irrigation, I can raise it up to maximum 60 millimeters mercury. I do put them on the same setting in terms of pressure. However, at the end of surgery, let's say the surgical time, the work time was the same, then typically the amount of irrigation is a little bit more and higher in biportal surgery. I believe that is because we have a We always want to have a nice outflow in biportal surgery. And because we have this larger outflow, inevitably we use a little bit more saline irrigation. I don't think it definitely affects the clinical outcome or it affects the complication rates only if you have a nice outflow. If you don't have a nice outflow because there's more irrigation, there's a high risk of water pressure related problems. But once you keep the outflow intact, it doesn't affect it that much.
Okay. Next question is your opinion on the choice uniportal versus biportal in case of multi-level diseases. Doesn't the number of incisions and area of dissections increases in case of biportal?
For single level interlaminar procedures, I always do uniportal, but for multi levels, 2 or 3 levels, I prefer biportal procedures. You can just do 2 levels with 2 biportal incisions, which means the invasiveness doesn't really get any larger than uniportal for multi-level procedures. I think it gives you a little bit more freedom inside there, so it's easier to do a little bit larger decompression inside there, which is not always a disadvantage. For certain pathologies, giving a much wider decompression is actually an advantage. So for multi-level diseases, I think I do more biportal.
Yeah, thank you. And next question in regarding the CSF leak with these procedures, any differences or?
I recently reviewed a article which was showing this the systemic analysis, systemic review of CSF leak in uniportal and biportal surgery. It says there's no difference in between the two differences. So the evidence says no difference in CSF leak. In my practice, once again, if you just keep the same principles, I think the principles for protecting the dura, the principles for avoiding CSF leak is not different in the two techniques. It's identically the same. So once you keep the principles, I think there's no difference in CSF leak risks.
Yeah, thank you. Next question about the fusion. Which one is the better and easier, technically easy probably, and for uniportal or biportal?
I think that's a very good question, actually, because I was told that the topic here today was discectomy. So I did not put fusion into the discussion. But in terms of fusion surgery, I need to admit it is much more easier and faster in biportal procedures. And uniportal surgery, just like I mentioned in my talk, the axis is a little bit constrained. So if you don't make a really, really optimal, nice angle to the disc in uniportal surgery, the procedure gets trickier and it's hard to put a cage in, aligning to the disc space. But in biportal surgery, there's much more flexibility and you have 2 different portals. Sometimes you can even switch the 2 portals inside your procedure. So it makes it much easier to do the fusion procedure. I do both uniportal and biportal fusion procedures, but to say which one is easier, biportal is far more easier and faster for fusion procedures.
Yeah, thanks. Yeah, and another question is about the learning curve. How many interventions it takes to be to a more stable result? I mean, uniportal or biportal? Yeah.
Yeah, well, I think it might be different in different surgeons' hands because one of the reasons that I predominantly do uniportal surgery is I feel uniportal surgery much easier in my hands. But many other colleagues of mine say that biportal is much easier in their hands. So number one, it might depend on the surgeon's preference. Number one, the evidence says that 20 to 30 cases will give you a good learning curve in the beginning. But once again, that will depend into different surgeons. But one thing that I can say is that once you are confident with one of the 2 different techniques, it makes the other technique learning curve much, much easier and faster. For example, if you are confident with uniportal, then starting biportal learning curve will be much easier. if you are already efficient with biportal surgery, adding uniportal will once again be much easier than starting everything. So I think it's really good to have both in your hands.
Okay. Yeah, thanks. And I just probably one of the last questions. It's any dural tears, and what's your management of the?
Yeah, I think there's no way you can say I have zero dural tears. That means you don't do surgery. You always can meet dural tears. So when I do suspect a dural tear, this is what I do. Number one is I see if the arachnoid membrane is intact or not. If the membrane is intact, and if the CSF is not actively coming out, if the nervures are not actively coming out, it always good to just use the sealing patches like Tecosil. You can just protect them with those. But if the CSF comes out and you see the nervures coming out, those cannot be sufficient as a sealing procedures. Then you might need to do suture procedures. If you already have the skills, you can do it with endoscopes. You can suture them. If you don't have the skills, you can just open it up. Or otherwise, recently you can use these surgical clips to close the dura. The one way that I identify the CSF leak and the arachnoid membrane intactness is when you're doing a local anesthesia procedure. You can simply turn off the irrigation and ask the patient to cough, and then you will see the CSF coming out. If you're doing a general anesthesia, you can simply once again turn the irrigation off, ask your anesthesiologist to do a Valsalva maneuver, and then you will see the CSF coming out. If you see the CSF coming out, you always need to repair it. If you don't see it, you can patch it.
Yeah, thank you. Yeah, it's a really hot topic because it's a question is coming and coming. And another question is like any information about complication rate, like post-op urinary retention for both techniques. And I don't know, it's
I don't have specific numbers. I don't have specific data or analysis, but I do occasionally see post-op urinary retention in both techniques. But I think it is more of a patient factor, a patient's original factor rather than a surgical factor. For these older age male patients, they tend to have a higher risk of urinary retention after surgery. I don't think it's really related to the technique itself.
okay. Okay. And I just my question is what is the optics? I mean, like arthroscope you use mostly like 30 degrees or 0 degrees, and in any differences or in based on some stenosis or herniated disc?
Yes, I think that's a really, really good and important question. Personally, I start with zero degree scopes. The reason that I prefer 0 degree is that there is no discrepancy between the real angle and what you see. That's the real actual angle. And I was started with 0 degrees. I was trained with 0 degrees. So I prefer 0 degrees at the beginning. But at certain procedures, I change the scope to a 30-degree scope. For example, when I'm doing a ULBD, bilateral decompression, when I'm reaching the contralateral side, I switch it to a 30-degree scope because it gives you a much better view of the contralateral side with this angle. It gives you a wider area of view with this 30-degree. So I think they have their own advantages, but if you understand how the scope works, it's really good to have both of it in your hands.
Okay, thank you. Yeah.
Farukh, I have one comment. Actually, with the biportal surgery, the water irrigation, some of the water comes out from your channel and then pours out on the side of the patient, as you have shown in your photographs. But in uniportal, it doesn't. Do you think we must be scared of for this pouring water onto the table.
Do you mean in uniportal surgery?
No, biportal surgery. The water comes out from the second incision.
Yes, that is right. Actually, we do not need to be scared of it because if you see the water coming out, it means you are safe.
But then the infection rate may rise up.
Yes, I think that's actually a good question because before starting this discussion, we need to understand the infection rate in both uniportal and biportal surgery is extremely lower than open surgery. I recently had a review. The open surgical infection rate is something around 3%, while endoscopic surgery is less than 1%. So basically, it's lower risk. But if we look into this outflow, the water which has come out through the outflow never comes back inside that flow. So it's coming out, never coming back in. So I believe the infection rate is not a really big deal. But why I think your question was really important is because when I did this research recently, the infection rate of biportal surgery was 0.1%, while infection rate of uniportal surgery was 0.001%. So actually, the infection rate was actually
10
lower in
times
uniportal.
different.
Yeah, so
Yeah,
I think your point is a really good point. Yes.
Yeah. One concern may be also the increase of intracranial pressure.
Yes.
With the uniportal, it may be higher risk. With
I
this
think it's
one,
the opposite.
it may be
I
lower.
think
Is it?
I think it's the opposite way. The water pressure
Is it?
related risk is higher in biportal because if you don't have this good outflow, second portal
Yeah.
open, then there is higher risk of ICP increase. But in uniportal, the water always instantly comes in and out through the same portal all the times. So actually, there's lower risk of pressure related problems.
Okay. Thank you.
Thank you.
So I think we have to move